So bilateral lower limb swelling with weakness can be a manifestation of systemic disease or a manifestation of local or loco-regional cause. Systemic diseases can be cardiac, like liver diseases, renal disease, as explained by my colleague, or it can be a local or loco-regional causes, which can be venous diseases, lymphedema, or a retroperitoneal obstruction to the inferior vena cava. So on examination, most of the findings of the patient were within normal limits. Only significant finding was her blood pressure is 150 by 90 millimeters of mercury. Performance status of patient was 1, and rest general examination was within normal limit. On examination of her lower limb, there was a bilateral pedal edema extending from foot to just below the knee joint, which was pitting type. Skin and hair over both of lower limbs were normal. No any dilated veins or erythema or ulcer seen over leg. On systemic examination, cardiovascular system, respiratory system, and per abdomen examination are within normal limits. To again summarize history and clinical examination of this patient.
No, your examination is incomplete. There is a patient with bilateral limb swelling.
Yes, sir.
Your examination is not complete. You didn't describe per rectal, per vaginal examination. If there is a pelvic mass,
yes, sir,
which is causing bilateral venous obstruction or lymphatic obstruction.
Yes,
no, he has finished the abdomen. He's come
sir,
to summary.
Yes, sir. We have done that, but there were no significant findings, so I have
You
not
have
mentioned.
to mention.
Yes, sir. Okay.
In the exam,
yes,
what
sir,
is not mentioned is not
yes,
considered.
Sir. Yes, sir. Yes, sir.
So I would add to what Dr. Kapoor is saying. You
Yes,
have
sir,
to mention the external genitalia, and you have to mention the hernial site.
Yes, sir. Yes, sir. Yes, sir.
And of course, the PR examination.
Yes, sir. To summarize history and clinical examination, our 62-year lady with gradual onset bilateral lower limb swelling along with generalized weakness for 1 month duration, and diagnosed case of hypertension and diabetes mellitus for 1 week. So we would like to evaluate this patient further. For this, we have requested for battery of investigation in which complete blood count, liver function test, renal function test, INR, urine routine microscopy, and viral markers all were within normal limits. In serum electrolyte, serum potassium of this patient was 1.6, which is below the normal limit of 3.5. Random blood sugar level was 398, which were above the 140 of normal limit, and HbA1c is 8.4. We also requested for chest X-ray, which is within the normal limits, and ultrasound whole abdomen, which shows the encapsulated heterogeneous mass of 8 by 10 by 12 centimeter in right suprarenal region, with increased internal as well as peripheral vascularity. So based on these findings, like ultrasound suggestive of suprarenal mass, patient is having hypertension and diabetes mellitus and hypokalemia. We will like to further evaluate this patient radiologically as well as in point of endocrine view. So first I invite Dr. Neha from Department of Radiology to discuss the radiological assessment of this patient. Thank you.
Good morning everyone. A CCT whole abdomen angiography and venography was advised. Here we can see contrast enhanced reformatted images in which we can see a large well-defined heterogeneously enhancing mass lesion shown here in the right suprarenal region. We can see that the mass invades the IVC lumen and the thrombus is shown by the blue label. We can also see that the mass is causing mass effect over the right kidney and displacing it inferiorly. However, no renal parenchymal invasion is seen. The right kidney can be separately visualized here and appears to be normal. This is a 3D model of our case in which we can see perilesional and internal vessels supplying the mass lesion. In the sagittal image, we can see the thrombus in the IVC reaching up to the hepatocaval junction, and the iotocaval junction appears to be patent. The mass is also displacing the inferior surface of right lobe of liver superiorly. Normally, we can see that the adrenal glands appear as inverted V or Y-shaped structures as shown in the first image. In our case, we can see that the right adrenal gland was not separately visualized, and on the left side we can see the normal adrenal gland. Here's a small clip of our case. we can see the mass lesion in the right suprarenal region. There is a thrombus in the IVC, which can be seen up to the hepatocaval junction. We can see there is no invasion to liver parenchyma. This was the left normal adrenal gland. The right kidney also shows no invasion. The fat planes are maintained between the hepatic and renal parenchyma. Here we can see that the right kidney shows no renal parenchymal invasion. To summarize our above image findings, we had a right suprarenal mass lesion with IVC thrombosis, and right adrenal gland was also not separately visualized. So possibility of a right adrenal mass lesion is more likely, and our probable diagnosis go in favor of adrenocortical carcinoma. The points favoring adrenocortical carcinoma are there's a large heterogeneously enhancing tumor with internal necrotic areas. We can also see IVC involvement, thrombus in IVC, and it shows less than 40% washout on delayed scans. So these findings go in favor of adrenocortical carcinoma. Now I would like to call Dr. Puneet on stage.
Thank you, Dr. Neha. A very good morning to everyone. So I would like to summarize the whole case. So she was a 62 years old, recently diagnosed diabetic and hypertensive female who presented with the complaints of bilateral pedal edema and generalized weakness. On investigations, we found hypokalemia and on CCT abdomen, we found a right adrenal mass. So this was the adrenal mass, as we can see here. It was 12.5 centimeters in size in its biggest diameter. It was hypervascular, heterogeneously enhancing, and there was a peritumoral vascularization, neovascularization. So based on these findings, we suspected the patient to have a adrenal malignancy, and we suspected pheochromocytoma or a adrenocortical carcinoma. So whenever a patient comes to us with an adrenal malignancy, what do the guidelines say? So we have to see whether the mass is functional or non-functional. So we have to do autonomous cortisol. For autonomous cortisol secretion, we do a overnight dexamethasone suppression test, and if we are suspecting pheochromocytoma, we have to do plasma-free normetanephrines. So we got the tests done. Plasma-free metanephrines and normetanephrines were within normal limits. Her overnight dexamethasone suppression showed the cortisol levels which were very high, and the ACTH was getting suppressed, meaning this was an ACTH independent hypercortisolism. So autonomous cortisol secretion was from the adrenal tumor. The plasma ACTH was getting suppressed due to the negative feedback inhibition, and with metanephrines and normetanephrines, we ruled out pheochromocytoma. So when we are suspecting adrenocortical carcinoma, we have to do sex steroids and precursors of steroidogenesis. So what is the rationale of doing these sex steroids? So if a patient is coming with steroid excess, it establishes the fact that the tumor is arising from the adrenal cortex. The pattern of the steroid also tells us about whether the adrenal lesion is adrenocortical carcinoma or not. For example, if there is an autonomous co-secretion of androgen and cortisol, or there is secretion of steroid precursors, it is highly suspicious of adrenocortical carcinoma. Sex steroids have got a prognostic value, and they are also can be used as a tumor markers during the follow-up. So having known about the importance of the sex steroids, I would briefly tell you about the adrenal steroidogenesis pathway. So here we can see that the first column is the formation of mineralocorticoids that takes place in the zona glomerulosa. The second column is depicting the formation of glucocorticoids that takes place in the zona fasciculata. And the third column is depicting the formation of sex steroids that takes place in the zona radicularis. So when we got the test done, we found that the aldosterone was getting suppressed. The cortisol levels were very high, and the androstenedione levels, that is the androgen, they were also very high. So by these hormonal profile, where there was very high cortisol levels and very high androgen levels, we suspected that a patient was having adrenocortical carcinoma. So why did our patient develop hypertension and hypokalemia? So in physiological states, cortisol is converted to an inactive compound called as cortisone in the presence of 11 beta HSD2 enzyme. Normally, cortisone does not act on the mineralocorticoid receptors. Cortisol has got mineralocorticoid receptor activity. In Cushing syndrome, when the cortisol levels are very high, 11 beta HSD2 gets saturated and does not convert into cortisone. So the high levels of cortisol, they act on the mineralocorticoid and they cause hypertension and hypokalemia. So with this, we made the final diagnosis of ACTH independent Cushing syndrome with hypokalemia, with metabolic myopathy, having renal adrenal mass, which was probably adrenocortical carcinoma.
Thank you, Dr. Puneet. I, Dr. Swapnil, from the Surgical Oncology department, will proceed the case. So our patient has an adrenal mass, and for its management, we follow the NCCN guidelines. So first of all, we stage the patient according to the 8th AJCC system. CCT whole abdomen was done, and the findings were already discussed. CCT chest was performed, and which was within normal limit. So here our patient comes under the T4 category, in which the tumor of any size with adjacent with involvement of the IVC. There is no any regional lymph node metastasis and no any distant metastasis. So our patient comes under the stage 3 prognostic group of the AJCC. For our patient has a tumor thrombus level. This is a representative image showing this is a IVC thrombus level. Extension into the IVC. So here the tumor thrombus is at the right hepatic vein and the IVC junction. So it comes under the level 3 of Nevis and Zinke tumor thrombus level. To modify further, here it could stage 3 be at the level of right hepatic vein at the junction of IVC and above it. So it could be either 3C or 3B. So due to the complexity of the structure and the planning of management, first of all we discuss the diagnosis that the 62-year-old lady with the right adrenal tumor of stage 3 along with the IVC thrombus level 3 along with ACTH independent Cushing syndrome, hypokalemia and metabolic myopathy. We discussed this case in the multidisciplinary team. What are the topics that were discussed what are the surgical approaches, IVC thrombus management, intra-op need of cardiac bypass, and the various intra-op and the post-op complications. So the final decision was preoperatively medical optimization of the patient, as this is a very highly vascular tumor. So during the intra-op we want to decrease the blood loss. So angioembolization of the major feeder vessels preoperatively followed by the surgery. Right adrenalectomy with tumor thrombectomy with retroperitoneal lymph node dissection. So we did a preoperative workup along with the counseling. Informed and written consent were taken. So as we discussed in the multidisciplinary team, for the angioembolization, I will request Dr. Siddharth to proceed further.
Thank you, Dr. Swapnil. I, Dr. Siddharth Dahiya, first year DM resident in Department of Interventional Radiology, will be presenting the pre-op angioembolization of the large right adrenal tumor. First, I will briefly discuss about the arterial supply of the adrenal gland. It is supplied by 3 arteries: superior adrenal artery, which is a branch of inferior phrenic artery; middle adrenal artery, which is directly arises from aorta; and inferior adrenal artery, which is a branch of renal artery. Now I'll discuss about the case. So in this case, left brachial artery access was taken, and guide wire and catheter were introduced into the aorta, and aortogram was taken. On the left we can see this is the video is showing the aortogram which was taken. It was taken to demarcate or delineate the vessels which are supplying the tumor. On the right in the image we can see that this is the tumor, and we can see the vascularity within the tumor. After the aortogram, super selective cannulation of the superior adrenal artery was done, and after cannulating the superior adrenal artery, we embolized it using the glue. In this video we can see that we are injecting glue within the tumor. On the image on the right shows the glue cast, which is mainly formed after the injecting the glue, and the video on the left, it is of autogram which was taken after the embolization of the superior adrenal artery to further demarcate the vessels which are supplying the tumor. So after doing the autogram, we again super selectively cannulated other feeding vessels to completely embolize the tumor. Thank you.
For the benefit of other students, non-radiology students, please explain what is a flush aortogram, what is a selective cannulation, and what is a super selective cannulation.
Sir, flush aortogram, it is done to see the origin of the vessels so that we can selectively go within the vessel which we want to go. Super selective cannulation, it is done with the help of the microcatheters and wires. First we take wire within the selected vessel, and over that wire we take the microcatheters, and then after entering within the vessel selectively, we inject our embolizing agent.
In this case, the first vessel which you embolized, was it originating from inferior phrenic, from the aorta, or from the right renal?
Sir, inferior phrenic artery.
So flush aortogram is when your catheter, please correct me, interventional radiology faculty, when your catheter is in the aorta and you inject contrast.
Yes,
here.
sir.
Then you went into the inferior phrenic.
Yes, sir.
Then you went into
then
the right artery.
Yes, sir.
So flush, selective, super selective.
Yes, sir.
Thank you, Dr. Siddharth. We will proceed with the case. After the induction of under general anesthesia, modified Makuchi incision was given. On opening of the abdomen, the following intraoperative findings: 18 into 15 into 10 centimeter highly vascular mass with firm consistency involving the right adrenal gland was identified, and due to this large mass, the liver was pushed up and out. IVC and the right renal hilum was obscured by the tumor. There is no evidence of disease any other abdominal organ in the peritoneum. There is no evidence of free fluid in the abdominal cavity. Followed by, we did a extended Coker's maneuver, due to which we are able to expose the whole right kidney along with the suprarenal mass and the full length of the IVC. Along with that, we did a piggyback liver mobilization, in which the liver was fully mobilized by dividing all of its attachment until it's fixed to the IVC only by the hepatic veins. So here we are able to get the full circumferential control of entire retrohepatic and the suprahepatic IVC segment. So this is an intraoperative picture in which due to the liver mobilization we are able to get the full exposure of the right kidney as well as the suprarenal mass. Followed by inferiorly the tumor was mobilized of the right kidney and the right renal hilum, medially by the IVC and the posteriorly from the lumbar vessels, and the complete tumor mobilization done of the diaphragm and the anterolateral wall. Followed, due to this mobilization, we are able to get the superior border of the tumor thrombus. This is a representative image. This is a right hepatic vein. This is the IVC. Due to the mobilization, we did a milking maneuver of the thrombus. So by milking this, we are able to get the superior border of the tumor thrombus below the right hepatic vein. So just below the right hepatic vein, the clamp was applied. So by doing this maneuver, the decision was that there is no need of intraoperative cardiac bypass system. So we are very thankful to the CTVS team who are agreed to be on standby intraoperatively. After the milking of the tumor thrombus, there was a sequential looping of the major vessel was done, which was suprarenal IVC, infrarenal IVC, right renal vein and the left renal vein. So after sequential looping of the major vessel, we have to address this IVC tumor thrombus. For that, I will like to invite Dr. Milind from the
Good morning, everyone. We'll take the case forward. I'm Dr. Milind Akhani. So, IVC being a major conduit of blood towards the heart, blood flow towards the heart, it has its own challenges for clamping. There is a sudden hypotension which can occur while clamping the IVC, which patient may not be able to sustain. So, we do have a very short window period during which we have to remove the tumor thrombus as well as we have to suture the IVC. And after checking with the anesthetist, we went ahead with the surgery. As you can see, we are putting two clamps, one above the tumor and one below the tumor. After adequate liver mobilization is done, the infrahepatic cava is properly exposed. You can see the tumor thrombus which has been removed from the IVC after placing the incision. The tumor preoperatively, as we could make out, was involving the IVC wall. So it was essential for us to take the margin of the IVC wall, which later fortunately turned out to be negative. As you can see, we have removed the tumor completely from the tumor thrombus completely from the IVC wall. The flow has been checked once again. Now we'll start with the sutures. As I told you before, we have a very short period or short window for suturing because we don't want the patient to suddenly destabilize. And as a result, we need to have a precise and immaculate suturing technique. More so because the walls, as you can see, there is discrepancy between the walls of IVC. So we we have to make sure that we do not compromise the lumen. There is no luminal compromise. Hence, the sutures are placed in such a way that there is a proper expanding of the IVC while the blood flow is there. So this is the final picture of the IVC after we have sutured. As you can see, you cannot make out that it has been really sutured, and there is any discrepancy in the IVC wall. I would like to call Dr. Swapnil Vanparia to proceed with the case forward. Thank you.
Thank you, sir. So to proceed with the case, we did a en bloc excision of the tumor along with the right side retroperitoneal lymph node dissection with the removal of right side pre-aortic, para-aortic and the aortocaval lymph node. Now, what can a surgeon do without an anesthesiologist? So, I would like to invite Dr. Ritu to discuss further.
Our challenges were adrenal mass of 12.5 into 8.5 into 8.2 centimeter of size with IVC thrombus, comorbidities like hypertension, hypokalemia, myopathy and type 2 diabetes mellitus. Our anticipated difficulties were that it was a major surgery with large incision, with increased risk of blood loss, risk of pulmonary embolism, chances of cardiopulmonary bypass, IVC clamping and thrombectomy, possibility of pulmonary embolism, major hemodynamic changes and fluid and electrolyte management during the surgery. Our anesthetic plan was to give general anesthesia, plus thoracic epidural analgesia under advanced hemodynamic monitoring with central venous catheter and intra-arterial pressure monitoring. Thoracic epidural was inserted for better pain management to reduce anesthesia requirement, neutralize hemodynamic changes during tumor handling and respiratory function improvement, post-op to support ERAS protocol. We opted for multimodal analgesia, which was repeated every 4 to 6 hourly. Dexmedetomidine infusion was started at the rate of 0.5 to 1 mics per kg per minute to decrease anesthesia requirement and analgesia and reduce hemodynamic variability during tumor handling. Patient airway was secured with oral cuffed endotracheal tube after induction with propofol, fentanyl and vecuronium. CTVS team was kept on backup for SOS cardiopulmonary bypass. In this graph showing the systolic blood pressure and mean arterial pressure changes during the surgical period. Baseline BP was 140 by 90. During first phase of the surgery, there was downward trend with occasional variation. Our first critical variation was during the actual tumor handling, where we encountered a spike in BP, for which we increased dexmed infusion and gave a bolus of labetalol with deepening of anesthesia. After that, there was progressive decline in BP, but it was within normal range. Before IVC clamping, patient was preloaded with IV fluid. Even after all this precaution, there was a fall in BP due to IVC clamping, which we managed with vasopressor support and IV fluid bolus. BP improvement after clamps were removed
Over the entire surgical period, there was significant blood loss which was replaced with 2 units of PRBC. Our intra-op ABG showed worsening of lactates and metabolic acidosis during surgical period secondary to the long duration of surgery, blood loss and sympathetic stress. ABG based corrections were done before the surgery was completed. Patient was kept on overnight ventilation, extubated on post-op day 1. Pain management was done with epidural top-up and IV analgesics. Hypokalemia was corrected. Normotensive blood pressure and euglycemia was targeted. Thank you. Now I call upon Dr. Kusha from Oncopathology to discuss about this case.
Thank you, Dr. Ritu. Good morning, respected teachers and dear colleagues. I will be discussing the histopathological aspects of this case. So, we received a specimen of right adrenalectomy which measured 15.5 into 12.5 into 9 centimeters and weighed approximately 400 grams. The outer surface was nodular and the capsule was intact. On cut surface, we found a very large bulky tumor which was friable in consistency and had areas of necrosis and hemorrhage. Distance of the tumor from the overlying capsule was less than 1 millimeter. We also received specimen of IVC thrombus, a revised margin of IVC and retroperitoneal lymph nodes. All the specimens were grossed, processed and routinely stained, and we proceeded further with the microscopic examination. So on microscopy at low magnification, we can see tumor cells arranged in nests as pointed by the arrow. At higher magnification, we can appreciate that the tumor cells were polygonal in shape and they were having moderate to abundant amount of eosinophilic cytoplasm, round to ovoid nuclei, granular clumped chromatin and prominent nucleoli. Clear cells were typically less than 25%. The third image is showing areas of necrosis which we found within the tumor. So this is the amorphous eosinophilic necrotic debris with loss of nuclear detail as pointed by the blue arrow, and this is the viable tumor cells present at the periphery. The tumor showed increased mitotic activity wherein we could see 1 to 2 mitotic figures per hyper field and also atypical mitosis as pointed out by the arrow. There was capsular invasion where we could see the presence of tumor cells, nests, which is pointed by the red arrow, which were present between the fibrous bands of the capsule as pointed by the blue arrows. There was evidence of vascular invasion as well, where we could see tumor cell nests as pointed by the red arrow, which were present within the endothelium-lined blood vessels, pointed by the blue arrow. You can see certain RBCs also here in the vessel. IVC was involved by the tumor, wherein we can see these tumor cell nests which are penetrating and infiltrating into the IVC wall, which is pointed by the blue arrow. Retroperitoneal lymph nodes show evidence of benign reactive hyperplasia. There were no tumor deposits seen in the lymph nodes. So based on the gross and the microscopic findings, there were few differentials which we considered. Malignant pheochromocytoma and adrenal cortical carcinoma were the closest differentials which we were considering. To further investigate and to differentiate between the entities, we employed immunohistochemical stains. So on immunohistochemistry, the tumor cells stained positively. They showed cytoplasmic positive expression for melan A, and melan A is a characteristic marker of adrenal cortical carcinoma, thereby excluding the possibility of a pheochromocytoma. Then the tumor cells also showed weak positivity for synaptophysin. Pan-cytokeratin was negative, and the tumor had a high proliferative activity with a Ki67 labeling index of 30 to 40%. So based on the above findings, we made a diagnosis of adrenal cortical carcinoma. To further corroborate our findings, we also use a modified Wise scoring system. So modified Wise scoring system categorizes the tumor as an adrenal cortical carcinoma, and it uses multiple parameters. Each parameter is assigned a score. So a mitotic count of more than 5 per 50 high-power fields and clear cell component less than 25% is each assigned a score of 2. Atypical mitosis, necrosis and capsular invasion are each assigned a score of 1. So the total score is 7. So if we get a score of more than equal to 3, it indicates a diagnosis of adrenal cortical carcinoma. In our case, all the criteria were satisfied and were met. So we got a score of 7 and the final diagnosis of adrenal cortical carcinoma was made. So my final diagnosis was adrenal cortical carcinoma conventional type with a pathological TNM staging of PT4N0 due to the involvement of the IVC wall. Now I would request Dr. Swapnil to please proceed further.
The plasma normetanephrine levels were normal.
Yes, sir.
Intraoperatively, in spite of such a large tumor, there was no hypertensive episode.
Yes,
Why did you put FIO as your first differential
Yes, sir.
diagnosis?
So that is because of the nesting pattern, sir. Adrenal cortical carcinomas, they generally have a trabecular pattern of arrangement of the cells. So this is purely a morphological differential which we were thinking.
So is it possible to have a malignant FIO without any clinical manifestations?
Yeah, many times we may have hypertensive emergencies, but sometimes we don't have hypertension in these type of patients. So it all depends upon, but manipulating a tumor sometimes leads to hypertensive evidences.
Anand, you wanted to say something?
Majority of malignant FIOs are non-secretive.
So you can still consider it as a differential diagnosis of malignant.
Thank you, Dr. Kusha. Patient was shifted to ICU intubated. At the post-op day 1, extubation was done. At the post-op day 2, orally sips of water allowed and the mobilization started. At the post-op day 3, patient shifted to ward and the Foley's catheter and the central lines removed. As the post-op day 6, drains were removed, and in between the post-op day 4 and 5, soft diet and the full diet was started. At the post-op day 7, patient was discharged. From the post-operative period, patient don't require any type of management for the hypertension. Hypokalemia was resolved by the post-op day 2, and the patient was on oral hypoglycemic drugs for the management of the diabetes. The histopathology report was discussed in the tumor board, and the patient was planned for the adjuvant radiation therapy. Here is the follow-up photograph of the patient. He is doing all her activities normally, and patient just on the oral drugs for the management of the diabetes. So I would like to invite Dr. Anand to proceed further. Yes, sir. So that is IVC. We send IVC wall that is show the vascular invasion, sir. This is IVC wall that is involved by the tumors. To thrombus, no, malignant.
Two types of thrombus. One was tumor thrombus, which was malignant. The other was clot. I think she takes. So from where the malignancy comes? Is it through the vein of the adrenal? Yes, sir. From the adrenal vein directly it is involved through the vein into the IV. Into the IV. So that if the vein is involved, then you have to resect the vein also. So we did resect. So we did resect. So the margins were clear. Yeah. So in the end, I think the video, that's why you see that part. But if you see, there was a good amount of margin which was resected. Told that the clot was floating. So the tumor was floating with the clot. So it is very difficult to differentiate whether it's a tumor clot or whether it's a blood clot. So what we do is before you open, you need to actually clamp top and bottom, and then remove the clot, which includes the tumor as well, and the blood clot.
Sir, no, sir. Such a large tumor clot in there, how are you going to excise it and remove it from the femoral vein, sir? You are going to still remove the tumor. The patient is open in front of you. You have the abdomen opened. You have a IVC which is involved with the clot. You don't want to close that, then again go through approach for femoral and then remove through that Fogarty.
And to just add, Fogarty may cause more dislodgement of the thrombus traumatic. Here we had direct access. It was in our hand. So I think this was. So just to conclude today's presentation, what were the challenges we faced? So adrenocortical carcinoma is a...
Is she coming for the radiation?
Yes, sir. She has completed her radiation.
Okay.
So adrenocortical carcinoma as such is a disease of rarity, and if you look at the worldwide literature, it is around 1 to 2 cases per million annually which have been reported worldwide. And to have a IVC thrombus through an adrenocortical carcinoma is very rare. Usually it is associated with renal tumors. So the other challenge was the patient had a suboptimal physiology, as we know that she was a performance status of 1 and she had slight cachexia and she had metabolic derangements, diabetic hypertension, in which endocrine department helped us to have the patient on table. Regarding the surgery, it was a difficult access. One of the most difficult access we know is the hepatocaval junction, and the tumor thrombus, as shown by Dr. Swapnil, it was reaching level 3 or B. First we attempted a suprahepatic control, but because of milking down, we could come down on clamping below the hepatic veins attachment to the IVC. Then IVC management, we thank our cardiac team, which was on standby, because if tumor thrombus is infiltrating into the wall, it may sometimes may need a bypass and may need a portal clamping, hampering the total vascular return from the bowel. And as it was also discussed, patients were explained about life-threatening complications such as air embolism, tumor embolism to the pulmonary side. Coming to the review of literature, there have been multiple case reports. The recent one has been from in 2022, one case reported from SGPGI Department of Urology, and predominantly it is very rare case, and the reports have been quite old. Coming to the review of literature with case series or major surgeons who have done the review of literature for ACC with a major vessel involvement. In this, it was published in 2004. They have reported around 8 to 10 cases, and only 2 patients were of 3A, 3B. Majority were 1 or 2 type, which is easy to manage surgically. This is by Professor Lauret and Chichi. He published in 2005. He did a worldwide literature review and could find only 127 cases reported in literature of vascular invasion secondary to ACC. And this is one of the case reports which includes ACC with liver and IVC resection for ACCs, because it's the liver and cava is in close proximity and poorly differentiated tumors can easily go. And all these papers have reported a perioperative mortality ranging from 15 to 30%. So to conclude, I would like to thank management of Mahatma Gandhi CCR Review Committee for taking out time from busy clinical schedule, and our all colleague allied branches, endocrine radiology, intervention radiology, HPV surgery, anesthesia, oncopathology, and cardiac team. Thank you.
Comment on the first part of the presentation. I wish and dream that all departments are led just as surgical oncology is being led.